Assalamu alaikum wa rahmatullahi wa barakatuh. In this recording, we are going to speak about one of the most important clinical stations for MRCPCH clinical exam. This station is the CNS station. For all candidates who are preparing for an exam, they will find difficulty in this station if they still at the beginning and they didn't start practice, okay, and they didn't see good varieties of cases. So in this station, as we know, it's 9 minutes. 7 minutes you are going to examine the patient and 2 minutes for discussion. This station, it's unique, different, and usually the examiner will have the impression from the first time you are going to touch or deal with the patient whether you are a good candidate or not. Let's say, for example, abdomen station, it's straightforward station, and usually it cannot differentiate between the good candidate who spent good time in preparation and the other candidate who may not have this experience with different varieties of cases. So in CNS station, with small, minute things, you can convince the examiner that you are a good candidate, and even if you committed some mistakes, actually they can recognize that maybe these mistakes are not intentional, and they even can ignore it and give you the full mark based on the skills you are showing and the conclusion you achieved. So what are the different cases I'm expecting in the exam? According to the statement, we can know what kind of cases. So in CNS examination, sometimes the statement is to examine motor system and that's it. That means upper limb, lower limb, and motor part of the cranial nerves. It's difficult, yes, it's difficult because time may not be enough to examine full motor examination, and sometimes the statement is leads to neurological examination for the lower limb. Okay, so there is difference between do motor examination and do neurological examination. So neurological examination of the lower limb means motor, sensory, coordination. Okay, if we send motor examination, so I'm doing only motor, and be sure that if your statement is do motor examination of upper limb or lower limb, so you are expected to offer after you finish your exam that you want to do sensory, coordination, and you want also to check upper limbs and cranial nerves. So you have to offer to the examiner your intention to complete your examination by doing this and this. Clear? For neurological exam, you cannot reach diagnosis with examination of only upper or only lower limb, or even without examination of cranial nerves. So it's very important. Maybe the time will not allow you, but you have to offer. So motor can be the statement. Do sensory examination, not common, but usually, as I mentioned, if your statement is do full neurological examination of the lower limb, that means sensory is required. And even if do full examination, so you have also to say that I would like to complete my examination with examining of sensation and coordination. Okay, so what cases I'm expecting in the exam? I'm expecting upper motor neuron lesions like spastic quadriplegia, spastic diplegia, and What else? Hemiplegia, okay, double hemiplegia, okay. What else? So these are the most common cases. And for motor examination also, I can expect some lower motor neuron lesion, like paraplegia, very common, especially spinal bifida case. And I can expect also floppy case like spinal muscle atrophy, which has different approach. Okay, so these are the most common, and if we are going to order according to the frequency, so the most frequent case and which is very famous in exam is spastic diplegia versus quadriplegia, and we have to know the difference because it's a very common question. You can refer and to your book and tell us what are the difference between spastic diplegia and quadriplegia, and the definitions of monoplegia, diplegia, hemiplegia, quadriplegia. Okay, it's very important, and also the discussion is based on your knowledge about the differences. What else I'm expecting in exam, the different cases? So I'm expecting as well ataxic cases, okay, so cerebellar lesions or sensory ataxia, or those cases having problem with coordination, whether cerebellar or sensory, like ataxia telangiectasia, very common, and also Friedreich ataxia also is less common, and sometimes ataxic CV, not common, but also one of the differentials you have to mention, and according to the findings. And what else? Okay, you can have in your exam a station of cranial nerve examination, also not common, but it can happen, and it's whether to be like do eye examination. Eye examination is because, as you know, cranial nerve examination, you are not expected to check glossopharyngeal, you are not expected to check vagus, okay, and olfactory. So the remaining are 9 nerves, okay. So one third of cranial nerve examination is eye examination, okay. So second, third nerve, and also fourth, sixth. So it's more than 1/3 of exam, almost half of your examination of eye examination, half of cranial nerves, I mean, is formed by eye examination, is, I mean, like 50% of cranial nerve examination, so it can be one station as eye examination. It can be as others, or it can be as CNS exam. Okay, so for sure everybody is going to be examined for CNS station. It's not like, as I mentioned, not like abdomen and others, not like musculoskeletal and others. What I'm going to do in the exam, okay, the steps. So once I log in, I have to greet the parents or the patient and introduce myself and telling what I'm going to do, okay, based on the statement. So I have to listen carefully to the statement. As I mentioned, according to the statement, it's the approach I'm going to follow. Okay, so what I'm going to do first, after I do these first steps, I'm going to take screening log. And the screening log is for the environment and for the patient. For the environment, what I'm going to search for, I have to search for any aiding devices or tools, any crutches, any wheelchair, what else, orthosis. So all like sticks, anything which I'm expecting that the patient is using for his disease. Okay, those kind, sometimes a case of, as I said, telangiectasia, we know that they are having immune deficiency. They are having immune deficiency, and they may have chest infections. So maybe you are expecting to see spirometer, and then you will ask yourself, why is spirometer in this station? So this is a very good clue. If you found any medication, you have to tell the examiner that I would like to check this medication. What for? Okay. So anything in the environment is very important. Presence of wheelchair may indicate that this patient is not able to walk individually or independently. So you have to ask if he's able to walk or not. I have also to check in the environment. Maybe he's not wearing glasses now, but maybe glasses is around on the table or anywhere. Okay, hearing device, anything. It's very important. Okay. Then I'm going to screen the patient himself. Okay, I'm going to check from head to toe. So head is very important because the first impression I'm taking about the head, maybe it's large, and don't say macrocephaly because you are not going to plot, but you tell your impression it looks large, but I would like to plot the head circumference on the curve for age. Okay, so you have to comment about this. What else in the head I would like to comment on? So if there is any dysmorphism, okay, any dysmorphic features, maybe this patient is having neurological problem associated with any syndrome. What else? If this patient having any obvious cranial nerve injury, facial nerve injury, he's having angle of mouth deviation, or what else? Maybe this patient is having any squint, okay, nystagmus, for example. So it's very important to pick this. Okay, what else? I have to try to start any conversation with the patient. Okay, like I say, good morning, how are you, how is school? This is very important because that will give me clue if he's having any problem with speech, okay, and what type of problem he has. Slow speech, like those having coordination problem. Okay. What else? So if patient is having large head, I have to check if he's having any VP shunt. Okay, ventriculoperitoneal shunt, and I have to actually ask for permission to palpate and see. So any obvious cranial nerve injury lesion, I have to comment on. Shall I do cranial nerve examination if I found any abnormality? No. Why? Because you don't have time, but you have to say that after I finish my examination, I'm going to do full cranial examination, okay, based on your suspicion. Okay, it's very important. And you keep continuing your screening look, and usually we comment on 4 Ds for any patient in the different stations. 4 Ds. What are these 4 Ds? So the first D is he distressed or not? It's very important, distressed or not. Second D, decubitus or posture. So how is he? If a patient was having sitting in a frog-like position, that indicates that he's having floppiness or lower motor neural lesion. So it's frog-like position as it's well known, so I have to comment on it. Okay, so decubitus, distress, and then dysmorphism. Okay, it's very important to comment on dysmorphism. And finally diet, okay, which we can say he looks tall for his age, but I would like to bloat, or he looks short for his age, but he looks thin for his age, he looks overweight for his age, but I would like to plot him on the curve. So it's very important to comment on that. So all this in the screening look, which I usually start with. And then based on the statement, I'm going to follow my approach. So if the statement is do full examination of the motor system. So what we are going to start? Are we going to start with the upper limb or lower limb? Okay, this is the trick. I prefer to start with the lower limb. Why we start with the lower limb? It will give you a lot of details which will help you to reach the diagnosis, to start with the lower limb. So how can we start with the lower limb? First, I have to ask for exposure. Okay, so lower limb examination, I have to if he's a boy, adolescent, okay, boy or girl, I have to respect the modesty, and I have to show the examiner that I'm asking for permission for exposure from like thighs till the limbs, and for upper limb I'm going to examine the full upper limb with the upper part of the chest. It's very important. And after exposure, so I have local examination starting with an inspection. So in lower limb examination, I prefer to do the inspection while the patient is standing. Okay, so if he is able to stand without support or without difficulty, okay, that will be great. Otherwise, I'm going to examine while he's sitting. So I have to ask if he's able to walk or not, and if he needs help during walking or not, because it's very important. Don't try to expose the patient to the risk to fall down. So I cannot ask him to start and assist the gait while he's not able to walk. And if that happened, unfortunately, that will be at least clear fail. So don't expose any patient to risk. They are assessing you as a good, safe doctor. So don't expose patient to any risk. So you have to ask if he's able to walk or not. And you have to show that you are keen about your patient, not to allow him to fall. So you are going to encircle him or just to be close to him while he's walking. So before he walks, you should assess him while he's standing, okay, and comment with inspection on both upper limb, lower limbs. Okay, what you are going to comment? You are going to comment on if muscle bulk, is he having wasting, is he having hypertrophy, or increased muscle bulk or decreased muscle bulk. Okay, any movements like fasciculations or abnormal movements. Okay, if he's having any swelling or contractions, very important. Scars in the CNS case is very important, especially what's known as releasing scar. Okay, so I will check tendon Achilles, it's very common site, and also sometimes muscle biopsy in the gastrocnemius. So this is very important. Sometimes some people, they have tradition of doing wasm scars like burn, okay, curative burn as they believe. So you have to comment on whatever scar you are seeing. Okay, so this is very important to comment with the inspection on to compare both limbs, if wasting or increased muscle bulk, any characteristic picture like cases of peroneal muscle atrophy, sharket my tooth, okay, so I have to check for like if they have inverted champagne bottle like and describe it. It's very important to be aware about the differences and what I'm inspecting. Okay, so this is for the inspection, and then for the palpation in new case, it's very important to know what you are going to do. So palpation in such case, you are going to postpone till you finish with the gait. Okay, so you did inspection initially, and then you ask the patient to start walking till like a few steps in the room. It's like not a big room. It's like 5 meters by 3 meters, for example. So you will ask him to walk. First, walk normal walk and see how's he doing. Don't just focus on his lower limbs during walking. Also check his upper limb. Maybe he's having the hemiplegic posture like this, okay, or like both upper limbs, so hemiplegia or diaplegia, and also I check his lower limbs if he's having scissoring or spastic gait while he's walking, okay, or if he's having while conduction gait, like patient who's hemiplegic with his exit upper limb having the same thing, okay, and what else? If he's having unsteady gait, okay, ataxic gait. So I'm assessing the gait while he's doing normal walking, okay. Then I do some tests to check if I was not able to reach a diagnosis like that. Then he went. I asked him to return back on his tiptoes. So if he is able to do tiptoeing walking, that indicates sometimes they are having tiptoe walking. Those cases of diaplegia or quadriplegia, they will have tiptoeing, okay, because of increased stiffness and contraction. So both there will be, and it will be impossible for them to do heel walking. So they are tiptoes. So then if I ask them to do heel walking, it will be very difficult for them. And by the way, most of cases will not be able to do heel walking. And then heel walking, okay, then what I'm going to do, I will do like folk test or side walking, okay. What's the importance of side walking? It's very important in case of subtle hemiplegia. So he will be about to fall if he's trying to like depend on the affected side. What else I can ask? I can ask him to run, okay. Also run can show if he's having a problem like hemiplegia, subtle hemiplegia. And I finish the gait by checking tandem walk or like heel to walk, and that will help us to know if he's having a problem with coordination, okay. And we have to know that normally all cases below 4 years are not able to do tandem walk. So usually I'm expecting the patient to be above this age to ask him to do tandem walking, unless it will not be helpful, okay. Then tandem walk forward and tandem walk backward. Forward 4 years, backward 5 years. Then what I'm expecting after all that, okay, if he managed to do all this, okay, still I am doubting that he may have sensory ataxia. So I will do a Romberg test, okay. I will ask him to stand and stand both and elevate both arms like this and close his eyes while I'm trying also to encircle him like this, and for a few seconds to check if he's having like unsteadiness or about to fall. Then I know that he's having a picture of sensory ataxia. Okay, so and also for sure we have also diaplegic gait we have to take in consideration, or waddling gait we have to take in consideration, like those patients having proximal muscle proximal muscle problem, like myopathy, like Duchenne or dermatomyositis. Okay, so I have to take in consideration the different pattern of gaits, and we can try to use YouTube to check the different type of gaits and to let your eyes be familiar with them. It's very important for the gait to be aware about, because in also musculoskeletal during BGALS you are going to ask for gait, so you have to know the different types of gait. Add to them that Trendelenburg gait and antalgic gait. Okay, we are going to discuss them later, but this is very important as the gait is your key for diagnosis of the case. So whether it's ataxic or not, whether it's spastic, what type of spasticity, and also for those who are having polynomial muscle atrophy, they will have lower motor neuron problem, they will have high stability gait. So a high stability gait like peroneal muscle atrophy or Charcot-Marie-Tooth or Guillain-Barré. Okay, so it's very important to know the differentials of what gait. And as we know now, after the gait, at least you reach it about 60% of the diagnosis of the case you are dealing with. As I mentioned, don't forget to check upper limbs during the gait and lower limbs as well, and be cautious not to expose the patient to any risk during the gait. Okay, then what you are going to do before you put patient back on bed to examine or to complete your examination, expose the back and check for any abnormality in the back, any kyphoscoliosis or any features like baby scar, surgery, anything you have to comment on. Okay, and it's mandatory if you found microcephaly, okay, to check the back as well. Most likely you have to exclude in such cases Arnold Chiari malformation. Okay, so it's very important, and it's actually clear pass, not clear pass, it's pass or fail criteria. As we know, there are some criteria which are considered as clear pass, and other criteria are like pass or fail. So examination of the back in case of microcephaly, it's pass or fail criteria. Okay, so now I'm going to examine the back, ask him to lean forward and check palpation of the vertebra, and as I mentioned, the importance. And then you are going to do the local examination of the lower limb. Okay, so what's the local examination? We finish the inspection before we ask him to do the gait, and then we are going to proceed with tone. Okay, tone of the lower limb. We do rolling of the both lower limbs while they are extended and the patient is in supine position. Okay, extending his both lower limbs. So we'll do like rolling movement of both lower limbs. Okay, at the level of the chin, like rolling. Okay, and the other thing that you elevate both from the popliteal fossa, like you are raising all of a sudden both lower limbs. Okay, just posterior to the knee joint and up, and see if it fall like this, like open poke. Okay, so that give you impression that there's low motor neuron. If it's hard actually to raise, and if sometimes when you elevate then the whole leg is getting elevated, that can give you impression that there is increased tonicity. Okay, so two important tests to check for tone in the lower limb. and based on that you are going to say there is increased tone or there is decreased tone. Okay, don't try to make it more complicated, like we say hypertonia, lead pipe, cogwheel, all these descriptions. Okay, maybe in adult it has its importance, but in our pets it's enough to say there is increased tone or decreased tone. And after that, what we are going to do, you are going to check power. Okay, and power is very important. Okay, because in power examination you have to check extensors and flexors. Okay, and comment which is having are going to grade. So your notes you have to tell the examiner that power here is better than there, and what's the interpretation of that. Okay, you have to compare power of both limbs together. Okay, you have to compare proximally and distally. Okay, the extensors group to the flexors group. Okay, so it's very important to reach your diagnosis. And as we know, the grading of power is 0, no movement at all. 1, there's some fasciculation. Okay. 2, there is a transverse movement with gravity. 3, there is movement against the gravity but without resistance. Okay. 4, we are offering light resistance, and 6, with strong resistance. So to check the power, first in the floor limb, it's very easy to ask him to elevate his leg, okay, on the rail of thigh, both, okay, without offering any resistance. If he managed to do this for both lower limbs, then you are going to start to give him some resistance by putting your hand and ask him to push against your hand, okay, and then you do the same for abduction, okay, and for abduction you are going to put your hands against this and ask him to push. It's very important when you give order for the candidate that he has to be able to achieve. Okay, so try to select the proper words which he can understand in a very clear language. Okay, and try to show him illustration so as to get good result and response. Sometimes you know very well what you are going to do, but the problem with the communication, okay, and sometimes he's anxious, he's not cooperating with you, so especially your situation will be very difficult if any other candidate managed to do these steps before you, because he was able to achieve good communication with the baby. So try to tell him what we are going to do and describe, and use a good language which is understood by him. So abduction, adduction, and flexion against, and then this is for the level of the thigh, and then you ask him to do some flexion of the knee joint and flexion of the hip, and you put your hands, okay, against both shins and ask him to push, and then you do the same, but you put your hands at the level of gastrocnemius and ask him to flex against your hands as well, okay, and at the level of the foot, okay, you check dorsiflexion and dorsal-extension, okay, so against your hand, and you offer resistance, and based on that you are going to tell your findings about comparison between both the limbs and proximal and distal extension, extensive extensors and flexors, and after that you are done with power. Then you are supposed to check reflexes, okay, reflexes is very important. Some of us have problem to elicit the reflexes and show the examiner how can we elicit the reflexes. So it's practice again, and you have to be aware also that sometimes once they see the hammer in your hand, they get frightened, and you have to comfort them reassure them and show you just strike on your hand and show that it's not painful, and we are going to strike here, and it's like a game. Okay, so in both lower limbs, what reflexes we are going? The very famous reflex is the knee jerk reflex. Okay, and I have to train myself very well. Check YouTube for the tendon knee jerk. Okay, and try first to palpate for the tendon. Okay, check the tibial tuberosity, and just like 1 or 2 centimeters above it, and then you strike and you ask him to relax, and then you strike and check the response. You have to expose the gastrocnemius in the quadriceps femoris muscle, okay, the thigh, during this, and you have to show the examiner that your eyes are focused on the thigh, not on the side of striking. Okay, and as I mentioned, don't let the candidate complain because of the strike you did. Sometimes it gives a bad impression. Then if you found the reflex like normal or subnormal, and you are expecting this reflex to be exaggerated, patient was having spastic gait and this posture and contractures, so in such case you think that maybe you are not able to elicit, so you show the examiner that you are going to do again the reflex, but you will ask him whether to do this, okay, and or to clench his teeth, okay, and repeat the reflex. Once you say you will count with him, and once you reach 3, okay, then you are going to strike and ask him to do this, like enforcing for the reflexes, and then you describe the reflex. So you did this for the tendon eject, and then you do also for the ankle reflex, okay, in both lower limbs. And we have also check YouTube for the reflex, and to train yourself where to strike with the hammer, and how you are going to show the examiner how confident you are and how safe you are. And as I mentioned, it's all about practice. Then you finish with this, you are going to do Papinitsky, okay, to check for upper motor neuron lesion. And as we know, when Papinitsky is positive, and what are the factors make it negative. So it's very important to know, and to also to train ourselves to do the Papinitsky. Sometimes we do with the hammer itself. Some examiners, they like to give you like tongue reversal and broken tongue reversal, and to check with the tip of the tongue reversal. They think that it's less harmful, or sometimes the key. So it depends on the examiner. And if you want to do abdominal reflexes, it's up to you, but usually by reaching the Papinitsky, you are about to finish. But remember, if you found hyperreflexia, according to presence of clonus, you are going to grade it. So you have to check for clonus if you found hyperreflexia, and we don't have to also to elicit clonus. You can check YouTube for this skill. By reaching the Papinitsky and ankle clonus, you are done with the motor exam, and you have to say I'm done, but I would like to complete. If the statement is do neurological examination for the lower limb, so you said I'm done with the motor, I'm going to do sensory. If you said no need, okay, so no need, we said okay, do the sensory. So I have to know that sensory examination, it has to assess crude touch, fine touch, crude touch and pain, both fine touch, and then temperature, okay, vibration, and proprioception, okay. So for crude touch and temperature, pain, we are not allowed to do that in the exam, okay. So we are doing only fine touch with a tip of cotton piece, okay? And we are going to check from proximally to distally according to the dermatomes, and I am comparing both dermatomes together in both limbs, okay? So I'm going to tell, I have to instruct to the candidate, to the patient, that I'm going to touch with this cotton and let him see what you are doing first. And please, after you close your eyes, tell me if I touch you or not, and in which limb, okay? So I'm doing this to check if he's having any sensory problem, which I'm not expecting in spastic diplegia or quadriplegia, so it's more for paraplegia, and I have to check for level as well, for motor neuron lesion, okay? So I have to worry about the dermatomes. Usually I start from medially to laterally. So after fine touch, I'm checking vibration. Okay, vibration, how can I check? Okay, I have to use tuning fork, which is 128 hertz. Okay, so I strike and then I put on any ball.